media player, presenters, and Q&A. You can modify your view by adding or removing a window just by clicking on these icons. We do encourage you to participate today by submitting any questions you may have into the presentation box, during the presentation. To do so, simply type them into the Q&A box and click submit. We will answer as many questions as we have time for in the panel discussion after all of the presentations. And just to note, our speakers today are all in the same room, and for safety reasons, they will be wearing face masks. I would like to introduce our first speaker, Dr. Tim Arun. Dr. Tim Arun is a clinical geneticist in the Division of Medical Genetics Department of Pediatrics at Ramatibodi Hospital, Thailand. Dr. Tim Arun completed her MD at Chulalongkorn University, Thailand, and is currently a member of the Asia Pacific Society of Human Genetics, the Genetics Society of Thailand, and the Thai Society of Pediatrics, among others. Please, Dr. Tim Arun, you may now begin your presentation.
Thank you, Michael. Thank you for introducing me. Okay. I think we will go to track control and then, okay, right now, is that, right, good. So thank you, Thermo Fisher, for inviting us to present today. So I will go through the genetic counseling for the chromosomal microarray in prenatal care. As you know, the microarray, I think that's like, oh yeah, the microarray is one of the genetic testing that can able to detect the small deletion and duplication, and it's become popular in the prenatal care setting right now. Because of the yield of the microarray, this is the trial in NICHD trial reported that about 6.5% of the cases with abnormal ultrasound findings has the clinically significant deletion or duplication from the CMA or chromosomal microarray. So the yield is high. Also, the yield in this study is about 4 to 7%. In the case that the trial do in the fetuses with the increased nuchal thickening and normal karyotype, and they found 4% of the cases with isolated NT has the abnormal chromosomal microarray, and also 7% in cases with increased NT with plus the other malformations. So the yield for the detection of the abnormal chromosomal microarray is like 4 to 7% in this study. And interesting data in another study, NICHD trial also did the study in the cases that have amniocentesis due to other reasons, such as like parental anxiety or just abnormal serum screening results, or history of a chromosomal abnormality in the previous trial, or just only advanced maternal age. And they found 1% of these cases has clinical significant deletion and duplication via the CMA. Another indications that study is the cases with the abnormal karyotype that show apparently balanced chromosome rearrangement from the karyotype, and they found 8% that has gain or loss at one or both of the translocated breakpoints by the CMA. So I think because of the yield is high, it's become more popular in the prenatal setting right now. So that's why we will talk about the process that include 4 steps prenatal or pre-test counseling, the informed consent, and interpret the result, and the post-test counseling. And I think the starting point, pre-test counseling, is very important. So we need to understand the result possibility, that it could become like positive, negative, or it could become like uncertain significance. And also, CMA also can detect the adult onset disease, and we need to provide this information to the couples or not. So we will talk to you later. And also it can detect the non-paternal and consanguinity. So that's all the concerning or challenging points that we will talk to you today. In the guideline, I'm sorry for the slides, maybe it's not good resolution, but in the guideline from the Society for MFM, they have like 5 recommendations. So the first and second, it could be like the indication or who that you need to like give the recommendation to. The first is the fetal abnormal ultrasound or stillbirth, that's the indication. And 3, 4, 5 recommendation is they recommend about the what the information that we need to provide. So I will skip this slide. Also, the guideline from the American College of the OBGYN also give the very good sample script for the counseling patients before do the CMA. And I think you can use this in your practice. So at first, you need to provide that what is the chromosome microarray. So you can give the information like this is the genetic test that examines the chromosome in finer detail than the karyotype or chromosome analysis. And the microarray so can find the abnormality that can miss from the routine karyotype. But it also means that sometimes the small abnormality or identified can be the uncertain significance. That means may or may not indicate a problem of the fetus. I think this sentence is very important that the couples need to know about what the possibility of the results. And also the addition counseling should be include that the CMA can identify the micro deletion or duplication, but it will not identify all genetic disorders. And the disease that if the result come back like positive, the disease may be identified, but the vary of the symptoms may be greatly and range from mild to severe, and it sometimes may not be possible to predict what the outcome will be in the fetus. And also, you need to give the information about consanguinity and non-paternity, and also the adult onset disease. So I think it's all the concern or the information that we need to talk to the couples. And also another guideline from the CCMGS-OGC in 2018. Also, I think in the same, but additional keywords. They recommend to have the formal informed consent, and this informed consent needs to be put the decision of the parents regarding the receipt of secondary finding. The secondary finding should be this decision should be communicated with the lab, because the report may be write down the secondary finding or not. It depends on their request. And also, I think the BCD is the same thing as others guidelines, like limitation of the test and what is the VUS and possibility of secondary findings and possible outcome. Also, the insurance and discrimination. I think in every country has not the same policy like universal coverage or insurance. I think you may need to identify in your clinical service. Also, we need to explain that sometimes it may be need parental samples for additional testing because of the interpretation of the result. And if you have the guide like educational material can be provided to them, that would be good. And also in the edge, they said like if the family is concerned about the risk of specific adult onset condition, they should also be counseled regarding the pattern of the inheritance and the appropriate testing options. Maybe the CMA is not the appropriate option. So I would like to just point out the 3 challenging points after we got the result. And this is like the post-test counseling. The first thing is the uncertain significance. The first step is we need the parental specimen that to look for that the parents have the same copy number variation as the fetus or not. If the result come like not, it's called like de novo CNV. That's more likely to be a pathogenic. But if it's not, but if in a different way, if we find the same CNV in one of the parents, it still cannot exclude that the fetus is normal. So I think all of this needs to be talked to them before the result come back, because sometimes the outcome is vary. So I suggest that if you have the results come back like uncertain significance, we need to refer the patients or the couples to the geneticist. And usually when we look through, we try to look at the specific genes contained in the deleted or duplicated regions that affect the fetus or not. So at the end, maybe we have some data enough to explain to them, but sometimes it's not because the limitation. The second challenging point is the secondary finding. So the suggestion is if the secondary findings reveals risk for a highly pregnant condition that has medical actionable during childhood period, it should be reported. But it's recommended that the lab not report the fetal risk for the adult onset condition unless the parents specifically request this information, or the secondary finding could be prevent serious harm to the health or other family members such as cancers susceptibility. And also the last one for the secondary finding is not reported non-actionable secondary findings such as like Alzheimer's. And the last challenging is region of homozygosity and the loss of heterozygosity and absence of heterozygosity. All of this is the same words. So usually it has been suggested to be greater than 10 to 13 megabits. So in the case that no history of consanguinity, they should report it. But if they know the history of consanguinity, usually not reported unless the specific request or the report can indicate that these regions are available on request. So usually recommend that them referring to the geneticist. So I think I would like to talk to you today, and just the take-home message, 3 tips: the communication skill, the information, and the attitude that you would like to help them. Thank you so much.
Thank you, Dr. Tim Maroon, for that very informative presentation. Our second speaker today is Dr. Takong, who is an assistant professor at Ramatibodi Hospital, Mahidol University in Bangkok, Thailand. Dr. Takong has a PhD in microbiology and an MD from Mahidol University, Thailand. He also holds the Thai Board's Certificate of Proficiency in Clinical Pathology from the Medical Council of Thailand. He has been part of multiple published research papers on genomic testing techniques and methods and holds a patent on biomarkers for dengue. Dr. Takong, please begin your presentation.
Good morning, everyone, and welcome to my presentation. First of all, I would like to thank you for coming here today. I'm Dr. Sukon from Ramatibodi Hospital, Mahidol University, Thailand. Today, I would like to present the laboratory aspect of chromosomal microarray analysis in prenatal screening. So, I will begin with you in filling you in the background of chromosomal microarray, or CMA. CMA is a molecular cytogenetic test used to determine if there are chromosomal imbalance called copy number variants, or CNV. Large CNV such as a whole extra or missing chromosomes is also detected by standard karyotype. Smaller extra CNV called microduplication or missing pieces of genetic information called microdeletions. CNV contributes to genetic variation of human diseases. CNV known to cause health or developmental problems is called pathogenic. The true extent of consequence related to the CNV depend on the particular genes gain or loss and how gene functions is altered when present in different copy number. CNV with unclear clinical significance is called variants of uncertain significance, or VOUS. VOUS has not been categorized as benign or pathogenic, either because too few cases have been reported in the literature or the affected gene content and function are not yet understood. CMA are commonly used in clinical situations, for example, pre-implantation genetic testing for aneuploidy or PGTA. Prenatal genetic testing is focused in this presentation. First-line test for individuals presenting with delayed development, intellectual disabilities, autism spectrum disorder, or multiple congenital anomalies. Genomic abnormality in cancer. In addition, it can identify submicroscopic aberrations such as small supernumerary chromosomes. Prenatal genetic testing may be offered to women during pregnancy to determine if the fetus can be born with genetic condition or congenital disability. Performing prenatal genetic testing may be useful in designing different options of pregnancy or spatial management of the pregnancy or delivery to improve the outlook of the baby. Finding conditions can assist in making decisions about the future of the pregnancy. The prenatal specimen for CMA depending on the gestational age and the purpose of the testing. For diagnosis, invasive procedures such as chorionic villus sampling or amniocentesis are performed to obtain a pure fetal materials about 11 or 15 gestational weeks respectively. For chordosynthesis, which is usually done after the week of 18 of the pregnancy. Use of chordosynthesis is becoming rare because diagnosis procedures such as amniocentesis or chorionic villus sampling, which pose a lower risk of the fetal death. In the event of fetal loss, product of conception can also be used. Unlike the conventional cytogenetic, CMA has not required the cell culture process of the sample, so it helps for a short turnaround time compared to the standard karyotype. Laboratory part, after extracted DNA from the sample, the DNA was fragmented and labeled with the fluorescent dye. CMA testing used a microchip platform which allow the analysis of many pieces of the DNA at once. The microchip use label or probe that bind to certain chromosome regions. Then it undergoes computer scan. The analysis compared to the patient DNA sequence with a reference DNA sequence. Any difference are called variations. Most CMA originally designed to detect genomic copy number using array CGH or to perform SNP genotyping. In array CGH, two DNA are labeled with fluorescent dye of different colors and co-hybridized to the single array to compare the copy number between a test and a control DNA sample. In SNP array, only a single test DNA is labeled and hybridized to the array compared to previously run controls. In addition to obtaining copy number information from the signal intensity, supplementally clinically useful information can be extracted from the genotype plots generated from the SNPs. So it can identify the mosaicism, twin-twin, maternal cell contamination, loss of heterozygosity or LOH, consanguinity, uniparental disomy or UPD, and triploidy. For the SNP array platform, the normal light intensity is typically plotted at the log2 ratio. You can see in the slide, where a log2 ratio of 0 represents a normal copy number of 2. In the lower part, the allele difference plot shows the various SNP genotypes for each SNP locus. This slide shows the cases of the female fetus with a 77.86 megabase gain along the chromosome 18, which is associated with a clinical diagnosis of the trisomy 18 or Edwards syndrome. In conclusion, for my part, CMA is a method for measuring gains and losses of DNA throughout the human genome. It can identify chromosomal aneuploidies and other large changes in the structure of chromosomes that would be otherwise determined by the standard karyotype. And in addition, it can detect the submicroscopic abnormalities that are too small to be detected by the traditional modalities. In addition, SNP arrays readily to detect both LOH and UPD. There are several limitations of chromosomal microarray. For example, microarray cannot detect balanced chromosome rearrangement, such as inversion or translocation, which do not result in deletion or duplication of genetic material. This test does not detect point alterations, small deletion or insertion below the resolution of this assay, or other type of variants such as epigenetic changes. This test is not designed to detect mosaicism, although it can be detected in some cases depending on the size of the locus, type of aberration, platform normalization, and calling algorithms. That's all of my talk. Please feel free to ask me at the Q&A session if you have any questions. Thank you.
Thank you, Dr. Tackle. It was a very insightful presentation, giving a nice overview of some of the important technical aspects of chromosomal microarray analysis. It gives me great pleasure now to introduce our third and final speaker in today's session, Dr. Panyu, Associate Professor and Head of Maternal Fetal Medicine Department at Ramatibodi Hospital in Bangkok, Thailand. Dr. Panyu completed his MD from Chulalongkorn University in Thailand. He also holds a Master of Medical Science in Assisted Reproductive Technology from Queen's Medical Centre, Nottingham University in the UK, and also a Diploma in Fetal Medicine from King's College in the UK. Dr. Panyu is an Executive Committee member for the Royal College of Obstetricians and Gynecologists of Thailand, and is a past president of the Maternal Fetal Medicine Division at Ramatibodi Hospital. Dr. Panyu has also been part of more than 20 published research studies in the field of maternal and fetal health. Dr. Panyu, I invite you now to give your presentation.
Right. Thank you very much for the nice introduction. Ladies and gentlemen, it's my great pleasure and privilege to join this conference on the overview of the CMA in prenatal screening test. As we know that G-banded chromosome analysis has been the standard method of for detection of the chromosomal abnormalities for years, and this method has several limitations, including the necessity of the performing cell culture, long turnaround times, as well as the low resolution to detect the chromosomal abnormalities less than 5 to 10 megabases. The development and the implementations of the CMA technology has ushered the new era of the clinical genetics. That's why we perform the study on the prenatal screening test of the fetuses with abnormal ultrasound detection by chromosomal microarray analysis. And in this study, Dr. Tim Arun and Dr. Charan Sutikun are in our investigator team as well. Okay, thanks to the prospect of the greater screening resolution brought by the CMA has emerged as the primary screening tool for many genetic diseases. Prenatal testing seems to be another field of the interest in the CMA. And the CMA can improve the identifications of the small genomic deletions, duplications that are not routinely seen on the conventional karyotyping. The copy number variants, the C and V, can be either benign or pathogenic depending on their location and genetic content. We aim to compare the conventional karyotyping with the low density chromosomal microarray analysis, and this is the prospective cohort study. We included all the pregnant women whose maternal age more than 18 years old, and all of them got to have their fetal anomalies diagnosed by the ultrasound scanning at Ramatibodi University Hospital. We also excluded the fetal death in utero as well as the patient's withdrawal. In our study, we expect to get the fundamental genetic data of the abnormal fetuses from the CMA technique in Ramadipati University Hospital, and we try to assess the CMA performance in identification of abnormal chromosome from abnormal fetuses when comparing with the conventional karyotyping. And this will give us the best data for genetics counseling for the couple. Regarding the methodology, the 97 pregnant women with the fetal anomaly diagnosed by the ultrasound scan underwent the invasive procedures such as the CVS, amniocentesis, and choreocentesis at the Ramadipati University Hospital from 2018 to 2019. And all of the specimens were sent for the conventional karyotyping at the CMA. Right. Okay, let's describe a little bit about our CMA platform in our study. The microarray in this study consists of more than 315,000 oligonucleotide probes, including more than 18,000 unique non-polymorphic probes and more than 148,000 SNP probes. This platform provides about 396 regions of prenatal interest. All the DNAs are determined and results were analyzed using the chromosomal analysis suite software. Sorry, got to go back. Right. And the program we used for the interpretation is a database genomic variants from the University of California, Santa Cruz genome browser. The CMV will not be reported if they are interpreted as a clinically neutral. The duplication and deletions less than 500 kilobases, or the RAS less than 10 megabases, and the terminal RAS less than 5 megabases. And let me talk about the items of the limitations. First, the balanced chromosome abnormalities, such as the reciprocal translocation, ribosomal translocation, inversion, and balanced insertions. And then the point mutations, the copy number changes just below the resolution of the array, low-level mosaicism, and finally the complete uniparental heterodisomy. The region of homozygosity, or RS, has the cutoff of 5 megabases. Anyway, the presence of the homozygosity more than 10 megabases, or at least 2 RS more than 5 megabases at each region is also reported, depending on the screening threshold. The IBD stands for the clinical biodescent is diagnosed when the regions of interest of allelic homozygosities occur on multiple chromosomes. And all segments within one chromosome is classified as UPD, which stands for uniparental disomy. Since the upward RS requires the high density SNP-based microarray, the RS opens up the new genetics approach beneficial for the UPD, parental consanguinity, as well as the autosomal recessive disorder. VOUS stands for the variance of the unknown significance. It's defined as the genetic changes that are not commonly seen in population and thus have the little or no clinical evidence available to assess their pathogenicity. The total amount of 97 pregnant cases were recruited, but 4 cases were excluded. Among these 4 cases, 2 of them underwent the endocentesis due to the advanced maternal age, and with the history of the previous fetal anomalies. Both of them had normal ultrasound findings. And another 2 cases, specimens were sent for either the karyotyping or the CMA only. So, therefore, 93 cases were analyzed in our study. Here, regarding the demographic profile, the mean maternal age is 32.6 years. The mean gestational age at the time of testing is 19.6 weeks, and the mean gravitas is 1.85. Right. Regarding the anomaly organs of fetuses detected by ultrasound, the 3 most common organs anomalies found in our study were the cardiac defect, about 23%, followed by the CNS anomalies, 18%, and increased nuchal translucency or cystic hygroma, about 15%. Right. Let's have a look at the number of the fetal anomalies organs detected by ultrasound. As you can see, the fetuses with 1 organ anomaly seems to be the most commonly found, 44% in our study. And the fetuses with 2 or more and 3 more organs were equally found, about 28%. Now, have a look at the other invasive procedures in our study. The endocentesis is the most common invasive procedures, followed by the CVS and the karyocentesis. This graph shows the number of tests comparison between the CMA and the conventional karyotyping identifications. The purple bar represents the conventional karyotyping, while the red bar represents the CMA. Then have a look. As you can see from the left-hand side is the normal result group. 28%, 28 cases detected by the conventional karyotyping, while 71%, 21 cases detected by the CMA. And then have a look at the abnormal group. In the abnormal group, in the concordant group, is found in trisomy 13, 18, and 21. And also the Turner syndrome and deletion. And in the discordant group, we found the duplication, inversion, VOUS, and ROS. Okay, this graph represents the ROC or receiver operating characteristics. In graph A, show the performance of the CMA for prenatal testing with the 95.7% sensitivity and 100% specificity. And the graph B shows the karyotyping performance with the 65.2% sensitivity and 100% specificity. And the graph C shows the performance of the combination of the CMA and the karyotyping for the prenatal diagnosis, which has the sensitivity and specificity of 100%. Therefore, the combination of the CMA and the karyotype seems to give the best performance for the prenatal testing. Now, the result of our study was divided into the concordant and discordant group. 70 cases in subgroup A had the normal CMA and normal karyotype, while the 14 cases in subgroup B had the abnormal CMA and abnormal karyotype. And then have a look at the discordant group. 8 cases in subgroup C had abnormal CMA and normal karyotype. And we found one case in subgroup D that had the normal CMA and abnormal karyotype. Then let's focus on the concordant group. In subgroup A consists of 70 cases with normal CMA and normal karyotype. In subgroup B consists of 14 cases with abnormal CMA and abnormal karyotype. Most of them are trisomies. Interestingly, we got 2 cases of the deletion. The first case, the baby had the bilateral ventriculomegaly and aqueductal stenosis. And the second one had the hypothyroidism, agenesis of corpus callosum, and congenital heart disease with a double outlet right ventricle and the pyelectasis. So Morvan-Wilson syndrome was diagnosed and confirmed by the ZEB2 gene deletion in this region. Now, what about in the discordant group? That is divided into the subgroup C and D. Let's get started with the subgroup D first. In subgroup D, there was the chromosome inversion in this region that can be detected by the conventional karyotyping, but not the CMA. And the mother has also the chromosome inversion in the same region. The baby has an increased nucleotranslucency at about 4 millimeters. Otherwise, normal finding by ultrasound. The baby was delivered without growth anomaly at the body weight of 3 kilograms. Then have a look at the subgroup C. This consists of 8 cases. We got 3 VOUS, 4 ROS. Interestingly, we got the microduplication of the critical region of Down syndrome. So this case, we diagnosed the Down syndrome. There were no statistically significant difference between the concordant and discordant groups in terms of the maternal race, gravida, social race at the diagnosis, and the number of organ anomalies. So for the CMA performance in the fetuses with the the CMA. Let me have to look at this one. Sorry. Okay. In our study, we showed the percentage between the conventional karyotyping and the CMA is about 90.32%, which is statistically significant. And the CMA detection performance in the fetuses with malformation diagnosed by the ultrasound is 8.6%, higher than the conventional karyotyping. Then let me talk a little bit about the limitations of our study. The limitation of our study is about the VOUS and the fetal autopsy cannot be performed in every cases. The whole exome or whole genome sequencing cannot be provided in all cases either. The RS report might provide the offensive information for the sex of the suspected the family consanguinity. And let's talk about the strength of our study. All the anomaly scan was performed by the maternal-fetal medicine specialist from the university hospital. And in order to minimize the bias of the two laboratories, these two laboratories did not know the result report of each other. The RS opens up the newest genetics approach, beneficial for UPD, prenatal consanguinity, and as well as the autosomal recessive detection. And finally, the diagnostic performance of the prenatal screening method were demonstrated in terms of the ROS or receiver operating characteristic. Right. Let me conclude. For the conclusion, there was considerable agreement of conventional karyotyping and chromosomal microarray analysis, especially in the detection of the major chromosome abnormalities. In the new frontier of the prenatal testing, the chromosomal microarray analysis seemed to provide more clinically substantial genetics data when comparing with the conventional karyotyping.